Good morning. Welcome to the first meeting of the Patient Protection Commission. I'd like to call this meeting to order and would like to ask staff in Carson City for a roll call, please.
Good morning. Chairman Packham. Dr. Barron.
Here.
Here.
Dr. Khan.
Present.
Ms. Flo Khan.
Here.
Dr. Slonim.
Here.
Mason Von Howling.
Here.
Bobette Bond.
Present.
Sean Schoner.
Here.
Yarlini Roa Duggan.
Here.
Jessica Flood. Teresa Bohannon. Barbara Richardson.
Here.
Heather Korbulik. Richard Whitley.
Here.
Have we established a quorum?
Yes.
A rhetorical question. I want to acknowledge the help of LCB both in Carson City and Las Vegas for all of the logistics that they've helped us with in this meeting today. Kudos to them. We're going to begin this and end this meeting with public comment today, and I believe we'll start up here down here in Las Vegas. If there's any public comment, please come to the microphones. Is there any public comment in Carson City? Hearing none, we will move on to a few opening remarks and introductions. For the record, I'm John Packham. I want to just state that it is an honor, a privilege actually, to not only serve on this commission, but to serve as the commission's chair and to work with this distinguished groups of leaders and experts from across the state of Nevada. I believe that this commission provides us with a unique opportunity to examine and address issues of healthcare access, affordability, and quality. With that said, I believe our task is fairly daunting. Nonetheless, I've had an opportunity to speak with most of the commissioners over the last couple of weeks, and I believe that everyone on this commission is committed to developing recommendations and strategies to the governor and to state policymakers that will begin to move the needle on the seemingly intractable issues associated with access and affordability in our state. I'd also like to acknowledge the leadership of the governor and state policymakers that turned SB 544 into this commission, and again, it's a privilege to work and serve on this body. Before we welcome the governor and our executive director, I'd like to give each commissioner an opportunity to very briefly introduce yourselves, and we will have an opportunity later in today's commission meeting to discuss each of the commissioners' vision and where they would like to see this group go over its first year. I would just briefly like to note that I've been employed for the last 20 years with the University of Nevada, Reno School of Medicine, or UNR Med. I currently serve as Associate Dean for the Office of Statewide Initiatives. It's a service and outreach unit of the School of Medicine. I'm also an Associate Professor in the Department of Internal Medicine, and I currently co-direct the Nevada Health Workforce Research Center at UNR Med. I think what I'd like to do in terms of introductions is maybe start with Carson City and maybe go left to right on my screen. I see Heather. If you will just briefly introduce yourselves.
Thank you. My name is Heather Korbulik, and I'm the Executive Director of the Silver State Health Insurance Exchange, which is the state agency that runs and operates the online marketplace known as Nevada Health Link.
Richard Whitley. I serve as the Director for Health and Human Services. Our agency has divisions of public and behavioral health, Medicaid as a relevant, I think, area for this discussion, welfare and supportive services where eligibility for the Medicaid population is still a area of focus for those who aren't enrolled, and aging and disability services, and finally division of child and family services. So we have quite a breadth of authority and payment for healthcare, and hope to serve on the commission to be helpful and provide what's needed for making the best recommendations.
So I'm Barbara Richardson. I'm the Commissioner of Insurance in the state of Nevada. I've been that for the last 4 years. We do solvency reviews, licensing reviews, market conduct. We work with all the carriers pretty closely. We only do the admitted market, though, which is it's a very small percentage or a slice of the pie of the entire health insurance market that we're going to be discussing. I would say, though, my background is not just here in Nevada, but I had 13 years as the Assistant Commissioner in the state of New Hampshire, and I also taught as an adjunct professor at the University of New Hampshire School of Law.
Good morning, everyone. My name is Teresa Bohannon. I am not going to go into my background because I'm currently not in the healthcare sector. I do have a background in public health. I worked for the Nevada Department of Public and Behavioral Health as a maternal and child health epidemiologist, but I'm really here to advocate for patients. I have a son with a chronic health condition, and so I will bring that focus to the commission.
Hi, my name is Jessica Flood. I'm Regional Behavioral Health Coordinator for the Northern Region. That position is funded through Division of Public and Behavioral Health, and I work for Nevada Rural Hospital Partners. So that position is really focused on bringing together diverse, non-traditional leaders in the community, such as law enforcement, emergency services, social services, mental health providers, et cetera, to try to improve the behavioral health system in the Northern Region. So that's Carson, Lyon, Douglas, Churchill, Mineral, not Mineral anymore, and Story counties. So I have expertise in behavioral health, mental health, and substance use, as well as the rural issues. I'm also Vice President for NAMI, so the National Alliance on Mental Illness, the Western Nevada chapter. I'm on the Human Services Network, and I teach for UNR School of Social Work. Thanks.
Thank you. Maybe start here on my far left with Mason.
Good morning, everyone. I'm Mason Van Houweling. I'm the Chief Executive Officer of University Medical Center here in Las Vegas. I've been in that capacity going on close to 6 years now. We are a 541-bed hospital, 4,000 employees. We have a lot of unique services at UMC. Obviously, we're known for our trauma center, our burn, transplant. We also operate a children's hospital, but also operate 16 clinics, providing access to patients in the community as well.
Hi, I'm Howard Barron. I'm a private practice pediatric gastroenterologist here in Las Vegas for the last 27 years. Immediate past president of Nevada State Medical Association. Have a faculty appointment at UNLV School of Medicine as an associate professor in pediatrics, and very pleased and honored to be here.
Good morning. I'm Dr. Anthony Sloan. I'm the president and CEO of Renown Health, a not-for-profit health system in Reno, Nevada. We have approximately 1,000 beds and serve the community broadly across a number of important services, including trauma in the Children's Hospital, with our 7,000 dedicated employees. I'm a physician by background, an internist, and a pediatrician with specialty training in critical care medicine, and I serve also as a professor of medicine, pediatrics, and community health at the University of Nevada, Reno School of Medicine.
I'm Dr. Ikram Khan. First and foremost, I need to thank the governor for his confidence in reaching out to appoint me on this very important commission. I've been in town in Las Vegas for 42 years. I'm a general surgeon, but I'm primarily focused as a president of Quality Care Consultants since 1992, providing consulting services in town to various organizations and groups. And the important thing I need to point out, I've served on various boards and commissions over the last 4 decades, but this is the first time I noticed in the charter of this commission that the governor has asked for this commission to come up with specifics to be considered at the legislative level. All the task forces and commissions in the past would ask for recommendations which generally went nowhere or maybe somewhere. So this is really something very special, and I look forward to it.
Good morning. Good morning, everyone. My name is Bobette Bond, and I feel the same way. I'm very happy that this is an organization and a charter that's going to have specificity to it. I worked for the Culinary Health Fund and have been involved in healthcare access and quality and affordability for about 28 years in Nevada. I really appreciate that this commission has a nonprofit slot, and I think that our 128,000 members that we provide health coverage for, and inside our Health Services Coalition, almost 300,000. We do direct contracting with the hospitals and the doctors. We have a health center. We provide the busiest 2 pharmacies in Nevada. So we're a healthcare coverage organization. We're also a healthcare provider directly in the community, and we're very interested in all the issues that are going to be facing this commission. Appreciate being on it. Thank you.
Good morning. My name is Florine Khan, and I am the Deputy Vice President of State Advocacy for Pharma. It is the trade association that represents the branded drug manufacturers. We, too, are pleased and honored that the governor has allowed us a seat on this commission. We look forward to working with all the members of the commission to come up with patient-focused solutions. And once again, we're thankful for being here.
Good morning. My name is Sean Shaner, and I work with United Health Group. We employ approximately 5,600 employees within the state of Nevada and have the privilege of working with and ensuring just over 950,000 residents within the state of Nevada across all 3 lines of business: commercial, Medicare, and Medicaid. Currently serve in the capacity of Vice President Sales and Account Management, and most recently moved over from the Network Development and Provider Relations Vice President position. Thank you.
Good morning. My name is Yarleni Roa Dugan. I'm a registered nurse at Southern Hills Hospital and also UMC. I do labor and delivery, and I'm also an executive board member of SEIU 1107, the local union. And my goal is to advocate for patients and the community at large. I feel very honored to be here. I seem like the youngest. Hopefully I will bring good ideas, fresh ideas to this commission.
All right. Thank you, Commissioners. It's now my pleasure to welcome Governor Sisolak and Executive Director Sarah Shulhagian. Welcome.
Thank you, Doctor. I appreciate it. Thank you for all of you for joining us here today. This is our first public meeting of the Patient Protection Commission. First and foremost, I want to thank you, all 11 members, and our Executive Director, Sarah, who you're going to get to know very, very well over the next few months, for agreeing to serve on this incredibly important commission. And as some of you had said, this is probably going to be unlike a lot of other commissions and boards that you might have sat on. I'm not looking for just 30,000-foot, recommendations. I would like specifics. We want the legislatures anxious to tackle this problem, and we're counting on you to bring your expertise to the table and help us get to where we need to get to benefit the patients and the citizens of the state of Nevada. When I signed SB 544, creating this commission, My goal was to bring together the brightest and most experienced professionals and advocates from all over our great state to take a comprehensive look at healthcare in Nevada and identify areas for improvement to ensure that every child, every senior, and every Nevadan has access to affordable and quality care. And I've always said, you probably all know, that quality care is only good if it's affordable and accessible. I feel that the commission that we have put together with your input, your service, is the best we could possibly ask for, and I really feel strongly that the citizens are going to be well served by the information, the ideas, and the dialogue that are going to precipitate from these meetings. As I often say, it's only quality if it's accessible and it's affordable. That's why I'm pleased to see that the PPC is going to closely examine healthcare costs in Nevada across the board to identify and address the primary factors driving those spiraling costs. Additionally, we must closely scrutinize the disparity in healthcare affordability and quality among different communities in our state. Every Nevadan should have access to good doctors and affordable quality health insurance, regardless of where they live or what their zip code is. Many of Nevada's challenges with healthcare are seen in states throughout our country. I'm headed out at the end of the week, the First Lady and I, to the National Governors Association meeting in Washington, and this is an ongoing topic that we have at every single meeting, healthcare. We're all grappling with these same issues. That's why so many have contacted me about how this commission is going, and I think that this will be used as a template in other states across the country to address healthcare. Some of these issues can only be addressed through strong action at the federal level. We realize that. However, I have faith that the team we have assembled here today can take a comprehensive look at our system and think creatively about long-term solutions that we can just begin implementing on the state and the local level. That's what Nevadans deserve. I know that solutions are out there with what my previous occupation on the county commission, what happened at UMC is extraordinary. And I think we can take the progress that we made there and put it on the state level and come up with new innovative ideas. Everyone who's serving on the PPC was chosen after a great lengthy discussion with my staff, and I've got the greatest staff in the world, I say that, but we put a lot of time into every single one of these appointments. We had a lot of applicants, and we chose who we thought would be the best in terms of representing our state. You were chosen because of your extensive experience and knowledge related to healthcare. Some in the academic space, some in the healthcare space, some who work at hospitals, others who have experience advocating for patients or working in the insurance sector. Each member provides a unique perspective based on their individual experiences. And it's a combination of those individual experiences coming together that I think are going to propel us forward and be so successful. But I want to remind everyone, this is extremely important, at the start of this endeavor, that the PPC, all of its members, are here to serve the people of Nevada. While you all have your own special interests, you're here as a group to serve the patients and the citizens of the state of Nevada. We welcome your diverse perspectives and institutional knowledge. But we also want to encourage you to never forget that the purpose of this commission is to protect patients, not anyone's individual professional affiliation, employers, or organizations. Nevadans come first, second, and third. I cannot emphasize enough just how important this commission is to me as governor and how important your work is. This is one of the proudest bills that we signed. I think this is an area that needs a tremendous amount of attention, and I'm committed to working with the legislative leadership to do more. For us to do more, we're going to count on you coming with specific recommendations that we'll be able to advance forward, not general stuff that we're going to have 120 days worth of discussion. I'd really like specifics. I'm counting on the commission, obviously, to work hard. I know you've committed to this. We talked to each and every one of you. This is a sacrifice on your part and your employees' part, and we appreciate that. But I ask you to remember that those most in need and most importantly solutions-oriented are what we need to get to here. That's the only way we're going to bring needed change and improvements to Nevada's healthcare system. And I want to encourage healthy debates among the members over major policy decisions. But those debates should always be productive and lead to compromise and a path forward. You're going to have differences of opinions. That's why you're all here, is because you're all experts in your own areas. You need to advocate for your own individual expertise and sectors, but also welcome the other input coming and seeing how we can mesh those together to move this mission forward. As you move forward, I and my staff will be monitoring this progress very closely and stand ready to support you in any way possible in terms of providing information, providing any expertise or data that we might be able to give to you, and make sure that you will have the information necessary. Thank you again to our founding members of this commission and agreeing to serve. You are being entrusted with an enormous responsibility, and I think all of you realize that to some extent. I think you're going to realize it to a greater extent as you get further into these meetings and see exactly what your charge is and exactly how far we want you to go and what we want you to bring forward. We're counting on you. We are counting on you in this interim time frame to transform the delivery of health care in our state to an entirely new level. And with that, I want to again thank you for your service, and I'm extremely proud. You all know Sarah. We put a lot of time into appointing Sarah to this position as well, and I'm so proud that she has agreed to accept this responsibility, because with the responsibility comes enormous opportunity, and I am totally confident that she is more than up to the task, and we look forward to working with you. So, Sarah, thank you very much.
Thank you, Governor. Good morning, Chairman Packham, members of the Commission. My name is Sarah Shulhagian, for the record, your Executive Director. I can't tell you what an honor it is to be here and to be accompanied by such an impressive group of people. My thanks to the Governor for having faith in my abilities and giving me this opportunity. I look forward to working with the members of the Commission in what I believe is a noble goal, making the lives of Nevada patients better. I echo the comments of Chairman Packham and believe that this is an important opportunity for Nevada and a tremendous challenge. There are many different views on this Commission, and that is what I believe will be our greatest strength, our diversity and our breadth of experience. I look forward to helping synthesizing these views to produce far-reaching recommendations that will change lives. That's why I took on this job, and I want all of you on this Commission and to every patient out there to know that my job is to facilitate your vision and to make this panel's mandate a reality. My door is always open, and I am excited about this journey. As the Governor noted, the Commission was created last session by Senate Bill 544 and I know all of you have read the bill, so I won't go into it in detail, but I will highlight the scope and duties of this Commission. The scope, as mentioned by Governor Sisolak, includes a systemic review of matters related to healthcare needs of all Nevadans and the quality, accessibility, and affordability of healthcare. Additionally, this Commission must attempt to identify and facilitate collaboration between existing state governmental entities and that study or address these issues. This Commission must submit a report to the Governor and to the Legislature twice each year, and it has the ability to create up to 6 subcommittees at a time. Finally, this Commission has the authority to request 3 bill drafts for each legislative session. As the Executive Director for this Commission, I encourage each of you to reach out to me anytime. I'm here to assist all of you, provide the support, and help guide our path forward. Mr. Chairman, that concludes my remarks. Any questions?
Any questions? All right. Thank you for joining us, and look forward to the work of the Commission. Next item on the agenda is a presentation of Nevada open meeting law, and from the Attorney General's office is Greg Ott. Welcome, Greg.
Thank you, Mr. Chair. They say in Hollywood you should never work with animals or children. I try never to follow governors, but apparently I failed today. Good opening remarks from him and from your chair, and I will try not to take up too much of your time. I know this is a valuable commission. I have committed to trying to do this in a quick manner, so let me see if I can do this. So open meeting law generally is found in Chapter 241. This is a brief overview. Like I said, you guys have a full agenda, so I will not take up too much of your time. I did include my full presentation because there are some tidbits that I will kind of gloss over, but it's good reference material if you have questions. I will also be available to you. I'm assigned as counsel to this public body, so feel free to ask me questions afterwards by telephone, by email, whichever works best for you. The applicability of the open meeting law is the most important aspect of this is that it's applicable to the Patient Protection Commission as a public body that was formed under Senate Bill 544 of the 2019 legislative session. And the other most important aspect of it is that it also applies to subcommittees. You've read the bill, you know that this body has the ability to create subcommittees. Know that each of those will also be bound by the open meeting law, so you will need to have those meetings publicly noticed as well. And as we get into a little bit of the quorum requirements and some of the danger zones to violate the open meeting law, things get especially dicey when you get a subcommittee because while your normal quorum is going to be 6 because you have 11 voting members, if you have a subcommittee of 5, that quorum of that subcommittee all of a sudden goes down to 3, and it gets very easy to have a conversation between 3 people that, while might be acceptable if it was something under the purview of the whole body, if it's under the purview of a subcommittee, that could violate the open meeting law. So just something to be very, very cognizant of whenever you are creating subcommittees, which you will likely be doing. The open meeting law requires that public bodies take their actions openly and that their deliberations be conducted openly. The Nevada Supreme Court has confirmed that the spirit and policy behind the open meeting law favors open meetings and that any exceptions should be narrowly construed. What this basically means is the legislature and the courts are going to assume that you as public servants with the advice of legal counsel are going to have an idea of what is required by the open meeting law. And so close calls are going to be construed in favor of the public and against the commission. So if there's something that is on the border and it goes to a court is going to say, well, the commission should have known better. It should have stayed away from that close call. And so we're going to err on the side of the public and make the commission go back and renotice it. So the baseball analogy would be the tie goes to the runner, the tie goes to the public in this place. Oh, now I've broken everything. Generally, the open meeting law requires public bodies to conduct open meetings with a publicly noticed agenda and provides full notice and disclosure of the topics to be considered. This is one of the slides where I like to ask us to take a second and remember that I think you guys understand that you're doing the public's business. And while the open meeting law requires us to write down what we're going to talk about 3 days in advance and post this and make all of our supporting materials publicly available and not communicate outside of these meetings, it can be very restrictive. It can feel like it's a burden. And the purpose behind that is really because even though you have a wealth of experience and you come from a number of different backgrounds across the state, there are areas that you don't have expertise in or that the public may have better ideas regarding. And the reason why our discussions have to be in public is so that somebody with a better idea out there in Ely or in Tonopah can take the time to come to a meeting or to see the agenda being posted and to come and watch the government at work and to participate in the discussion as necessary. So even though it can feel burdensome and it can feel onerous, it really is important to make sure that the public has a window into the jobs that you're doing because it will, as the governor stated, affect all Nevadans. Having said that, public bodies are a collective. So even though you are all individual members, action must be taken by the whole. So individually, you can't speak for the commission or take any action. So the action of the body must be taken by a vote. The exception to that would be as if the public body expressly delegated a decision-making power. For instance, sometimes during a legislative session, the public body will delegate the chair to go give testimony or an individual member to go give testimony and speak on behalf of an issue that they have already decided. So what is a meeting? We talked a little bit about the purpose and the broad scope of the open meeting law. A meeting is defined in NRS 241.015, and it requires 2 things. One is a quorum. We talked about that. Generally, it's a simple majority of the members. So here it's going to be 6 unless we're in a subcommittee, and then it's going to be a simple majority of the subcommittee. And then it's going to require either deliberation or action. So there is an exception. Well, it's not an exception because you're not deliberating, but if 5 or 6 of you were to attend a social function, Super Bowl party, for instance, and you're talking about football, talking about your kids, schools, whatever, you're not deliberating, you're not taking any action on behalf of the public body, so therefore there's no open meeting law violation. Whenever you do get that quorum together, there is the potential that something could happen. Somebody could have a traumatic head injury in the Super Bowl party, and then all of a sudden someone says, oh, that's something we should talk about, and you can spark that conversation that can get into deliberation regarding items that are within your discretion, so be careful. But generally, as long as you're not deliberating, you're not in a meeting, so the open meeting law would not apply. There is also another exception here, which hopefully it doesn't apply to you, because it's an attorney-client conference regarding potential or existing litigation. So in order for that to apply, you have to be facing potential or existing litigation. Hopefully that doesn't apply, but if it does, you're allowed to have a conference with your current attorney outside of an open meeting for obvious reasons. What is a meeting? This, I think, is one of the most important slides because it talks about serial communications and walking quorums. Technology is a great thing. It allows us to communicate very easily. Text messages, group emails, all these things allow us to get information out quickly. It's also a very easy and quick way to violate the open meeting law because you can send a text that can then get forwarded to another person, and then they forward it to another person, and then 1 + 1 + 1. Quickly, you can get up to 6 or 7. Also, a reply all is a very dangerous thing because you could send an email just saying, hey, I'm going to be a little late to the meeting, and somebody says, well, that's okay. I really hope you don't show up because I don't want you to vote this way. And then you all of a sudden have violated the open meeting law just because you were trying to tell somebody you were late to a meeting. What I generally recommend is don't email each other. If you need to have something disseminated to the group, make use of your executive director, make use of your administrative support. She can send an email to herself, blind copy everybody else, and then you're prohibited from that dangerous reply all button. She can also put things on the agenda so that you guys can make sure it gets talked about at a public meeting. Really use your staff as a safety valve to keep all of that deliberation and action pushed in front of a public meeting so that you don't wander into an open meeting law violation really without any sort of bad intention, because in all of the open meeting law violations I've seen, it's all people trying to get things done expeditiously and trying to do good work. They just do so in ways that are not as transparent as they should be. Meeting notice and agendas, these are more going to apply to your chair and to your executive director who will be putting those together for you. They do need to be posted 3 days by 9 a.m. the third working day before the meeting. So just know that if you have something that you want to talk about at an agenda, you feel like you need an agenda item on there, it's not as easy as just putting something out there a day or so before the meeting. These things are normally getting prepared weeks in advance so that the chair knows to get speakers lined up and the executive director has the appropriate support materials. So there's a significant lead time to these agendas. And whenever executive directors or chairs call me, 2 days before the meeting and say, hey, can I add something? I always say no. So it's not their fault if your item doesn't get added. It's probably mine. Clear and complete is one of the keystones of the open meeting law, and that is when you look at your agenda items, they must be clear and complete such that a member of the public will be able to read the item and understand what's going to be talked about. And the way that I ask people to think about this is you are all experts in your field. You understand acronyms, you understand special language, and you understand things in a way that members of the public often do not. What I ask is when you're looking at agendas or when you're thinking about preparing these things is that you look at it from the perspective of somebody who's not an expert in their field or somebody who doesn't have significant experience. Because really the agenda is there for the public, not for the public body. It's to let the public know what's going to be coming. So it has to be clear enough and complete enough so that somebody out there who hasn't been watching all the various going-ons of the commission can read it and understand what's coming and know if they want to attend and provide some comments. Also, a higher degree of specificity is going to be required whenever there's a topic of substantial public interest. So if there's something you know is going to be a hot button, put in a little bit of extra work to make sure that that has additional detail in there because we know that the public is going to want to see that one. These are some additional requirements for the meeting notice and agenda. Of note here is the chair's power to take items out of order and to combine items if necessary. I generally say if you don't like the way the chair does that, you can vote him or her out of office. However, the chair is appointed by the governor in this case, so you have no ability to check his power except to take it up with the governor. These are further additional requirements of the open meeting law. Mostly they will apply to the executive director and the administrative support. Some more additional requirements. These primarily govern the requirements to provide information to the public. So in addition to posting the agendas, the public is entitled to copies of the agendas. Public is entitled to copies of minutes. The public is also entitled to copies of support materials. So anything that this body is going to be getting from its executive director or from other agencies, I know there's a provision in 544 that allows you to get information from other state agencies. Those support materials are going to become public documents that have to be disclosed to the public and that the public is going to have an opportunity to view. Minutes will be kept, and those will discuss the substance of the matter, the members in attendance, and the remarks by members of the public, if so requested. But just know that you will have additional requirements to provide information to the public and provide documents to the public. Exceptions. People's eyes light up sometimes when I talk about exceptions. Know that they are narrow and few. Closed sessions are generally not available, but they are available if you're considering the character, alleged misconduct, or professional incompetence. Probably not something that you will be doing. There is also a provision for emergency meetings, but when we talk about emergencies in the open meeting law context, we're really talking about life safety issues. If there's really something that the body would need to meet on immediately, probably not going to ever apply to this public body. Public comment pitfalls. You'll note on your agenda that there's 2 public comment periods. That will generally be the case. Public comment must either be taken at the beginning and end of a meeting or before every action item. Public comment can be limited by time, can never be limited based on the viewpoint of the speaker, or if we don't like what the speaker is saying about the board or members of the board. However, you don't have to have your meeting ground to a halt by unruly public. You do have the ability to remove people if they are disrupting the meeting. I do recommend that you warn people repeatedly to calm themselves and to act appropriately before you remove them, because you're almost certain to get an open meeting law complaint if you do remove someone from a meeting. And people should have the opportunity to attend meetings, even if they are becoming a little bit unruly. The first response should not be to try to remove them from the meeting. Violations. First and most importantly, actions taken in violation of the open meeting law are void. That comes from 241.036. So if you do take an action that wasn't properly agendized or that didn't have a clear and complete agenda item, it's going to be void. You're going to have to go back and do that work again. You have to renotice it. You have to have the discussion again, and you'll have to have another revote, which is valuable time away from you guys getting on to the next item. I know that you have a full plate of things to consider. It will take us some time to get through all of that. So if you do slip up, it's going to just delay you. The Office of the Attorney General has statutory enforcement powers under the OML and the ability to investigate and prosecute. Individuals can also bring actions to have items declared void if they believe that something has gone on that was violative of the open meeting law. And corrective action is prospective only, which means if you go back and if you have violated the meeting law and then at your next meeting you go ahead and re-agendize it and do it correctly, that will be effective as of the next meeting. It won't go back to retroactively validate the prior action. Although we do still encourage you to do that if necessary, because it's better to correct it sooner rather than later. Corrective action does require independent deliberative action, so that means you can't just rubber stamp the discussion you had previously. You need to go ahead and have the discussion in earnest again, make sure that you come to the same conclusions, because the public is due a window into that deliberation. It's not enough to just ratify the prior action that was taken. Using technology for a meeting, this is one of the bright spots. As you can see, we have members in Carson City. We have members down here in Vegas today. Technology is something that is very useful, especially when you have members across the state. Perfectly acceptable to have members in different locations. You can have quorum created by people via teleconference. You can have them via telephone. So if you do run into a situation where you need to have a meeting on short notice, you can make use of some of these technological avenues to make things a little bit easier to get your quorum established. So keep that in mind if and when things become difficult to get a meeting together. Ethical considerations. The ethical considerations of public officers are given in Chapter 281A of the Nevada Revised Statutes. You heard the governor talk today about how you all have been appointed for your experience and your expertise. The duties of the commission are given in Chapter 8, I believe, of SB 544. So there is a tremendous list of things that you are obligated to do, and you have to commit your duties with the ethical considerations in mind of Chapter 281A. I will not go through all of them here, but I would recommend that you take a look at 281A 400 just to make sure that you refresh yourself with the obligations that you have as a public officer to go ahead and conduct your duties with the highest ethics. Legislative update. I don't think we need to talk about that. There are administrative fines, but don't be afraid. The administrative fines are really only appropriate for willful and intentional violations of the open meeting law, so you're not going to be able to stumble your way into a fine. You have to sort of be advised by your attorney that you're about to violate the open meeting law and then say, oh, that's okay, we're going to do it anyway. That's the kind of thing that a fine would come into effect. Couple of additional points. We get a lot of questions on parliamentary procedure, motions, seconds, things like that. None of that's actually addressed in the open meeting law. Most public bodies and commissions adopt Robert's Rules of Orders for the parliamentary procedure that they go through. I think it's a good way to make sure that everybody's views are heard, but it's not required by Chapter 241. Here's some additional resources. We do have a open meeting law handbook that is available on the Attorney General's website. There's a link to it there. Chapter 241 has the entirety of the open meeting law. There's a link to that as well. We also have a DAG to assist with OML issues each day, but you can also contact me as well. My information is not on here, but my phone number is 775-684-1229, and I will make my email available to you as well, so that you guys can reach out to me. I'll also be available here the rest of the day today and after the meeting as well if you have any questions or concerns about the open meeting law. And that's all I have.
Thank you, Greg. Any questions for Mr. Ott? Any questions in Carson City? Thank you. Now I want to turn to agenda item 6 and ask Marshila Lyons, who I believe is in Carson City.
Good morning.
Welcome.
Chairman Packham and members of the Patient Protection Commission. For the record, I am Marshila Lyons, Deputy Research Director of the Research Division of the Legislative Council Bureau. The Bureau is the nonpartisan staff of the Nevada Legislature, and the Research Division is the branch of the Bureau charged with responding to legislators' requests for information, background, research, and policy analysis as they make policy decisions and respond to constituent concerns and questions. In an effort to provide legislators with relevant information on a variety of topics, we frequently prepare publications that pull from various resources. Our aim with these types of publications is to give legislators and members of the public an intelligent overview of a topic or subject in a clear and concise format. Before I dig into the document that's before you, I'm going to give Megan Kamlasi, another staff member from the Research Division, an opportunity to introduce herself and tell you a little bit about the other committees during the interim that are working on healthcare issues.
Good morning, Chairman Packham and members of the Commission. My name is Megan Kamlasi. I am a Principal Policy Analyst with the Research Division of the Legislative Council Bureau, and I am staffing the Legislative Committee on Healthcare this interim. Have been out for a few months, but I'm back now. And we've heard from a number of legislators who are very interested in working with this commission. They're excited about the work that you guys are going to be doing and would like to work with you. There are also a number of committees, legislative committees, that are meeting during the interim that are working on health and health-related issues. We have the Legislative Committee on Healthcare, which has a very broad purview. There's the Legislative Committee on Senior Citizens, Veterans, and Adults with Special Needs, as well as the study this interim to look into the cost of prescription drugs. So there are a number of overlapping areas depending on what you all choose to look into. And I would just welcome Chairman Packham and your Executive Director to reach out to us so that we can work together, talk to our chairs, and see what these legislators are interested in working on, and try to avoid duplication and be the most efficient public bodies, getting the most good done for Nevada possible. So please feel free to reach out to me or Marshila as you move forward so that we can all work together. Thanks.
Thank you, Chair Packham. Again, Marshila Lyons for the record. So my aim today is to provide you with a quick look at certain healthcare and physical health data in Nevada and how they compare to national averages. I'm hopeful that these statistics and rankings will assist you as you meet the responsibility and purpose of the Patient Protection Commission. The vast majority of the information provided may be found in greater detail at Sage Stats. Sage Stats utilizes over 400,000 data sets about U.S. geographies from over 250 authoritative sources to provide consistently formatted statistical data series to use when conducting social science research. Other sources I want to mention include the National Center for Health Statistics, Stat of the States from the CDC, State Health Facts from the Kaiser Family Foundation, and the 2019 Annual Report from America's Health Rankings. Links to all of those sites may be found at the end of the fact sheet on page 4. I also want to thank the Department of Health and Human Services for their help verifying and providing updated information. As you review the data, please note that the rankings are from highest to lowest of the 50 states in the District of Columbia. I won't walk through all of the indicators listed, but I hope to highlight a few challenges Nevada has, and in categories where we have strengths, to highlight those as well. Finally, I'm not a statistician or economist, so in the event you have questions that require us to dig a little deeper into the information that's provided, we're happy to take those down and respond to those questions for you and provide you with greater clarification. So just getting started in what you have before you, and you should all have a copy before you of the healthcare statistics and rankings. Starting out, we know that one of the primary ways that people are able to access healthcare is just cost, and that's one of the things that limits. And so we've kind of broken it down to talk about financing both from a state and local government level, and then looking at health insurance coverage in the state and Medicaid and Medicare coverage. So in the financing, we have the per capita state and local government expenditures for health programs. And for that area, Nevada ranks 41st with $486 per capita versus the national average of $825. Percent of state and local government expenditures used for health programs, again, we rank 32nd in the nation, with 6.9% in Nevada, and then 9.3% is the national average. For health insurance coverage, I won't point out all of these, but just a few of them. Nevada, under the percent of population not covered by health insurance, we rank 8th in the nation, with 11.2% of the population not covered by health insurance, and 8.7% is the national average. This is an increase from where we were some years ago. So after the expansion of the Affordable Care Act, we were able to bring those numbers down considerably. The percent of children not covered by health insurance, we rank 2nd in the nation, and that's second highest at 8%, and the national average is 5%. Going down to employer-based health insurance, the percent of the population covered by employer-based health insurance, we rank 34th in the nation with a percent of 48%, and the national average is 49%. Looking at the percent of private sector establishments that offer health insurance, in that area we rank 24th in the nation, and Nevada at 47.8%, and the national average of 46.8%. Looking at the percent of population covered by public health insurance, we rank 29th in the nation, with Nevada ranking 33%, and the national average at 34%. Going on into the topic of Medicaid and the Children's Health Insurance Program, the estimated per capita medical expenditures in Nevada are $1,309 versus the national average of $1,844, ranking us at 39th. The estimated Medicaid expenditures as a percent of the total state expenditures, we rank 21st in the nation at a rate of 28.5%, and then 29.7% for the national average. The percent of population enrolled in Medicaid and the CHIPS health insurance program that we rank at 27th with 19.4% in Nevada, and then 21.5% is our national average. And the percent of Medicaid enrollees in managed care programs, we rank at 18th in the nation with a national average of 81%, and Nevada ranking at 87.7%. For Medicare, the percent of total population enrolled in Medicare, we are 43rd in the nation, ranking with a percent of 17% for Nevada, and then 18% for the national average. I will spend a little bit more time kind of going over the providers categories. While this information is somewhat dated, because we were not able to find it in a format consistent with how we have produced this document, when we did find individual indicators of physician-provider rates, it seemed consistent that we were not reaching the national average in a lot of these categories. So just keep that in mind as we go through this, that although it's dated for some of these indicators, we still were not reaching the national average. So the rate of physicians per 100,000 population, we rank 47th. The rate of primary care physicians per 100,000 population, we rank 49th. The rate of registered nurses per 100,000 population is 48th. The rate of licensed practical and licensed vocational nurses per 100,000 population, 46th. And so you can kind of see a theme going here as we go through these, that these are areas, provider rates in Nevada, having adequate providers in Nevada is really a challenge. And it's even more of a challenge as you start looking at some of the rural areas of the state. So the rate of psychiatrists, 50th. For a surgical specialist, 51st. General surgery, 50th. Pediatrics, 49th. Physical therapist, 45th. So good news, dentist, 25th. So we're better there. And I point that out also because I would say 10, 15 years ago, we were not ranking very high there. And there was a concentrated effort on the part of policymakers, such as those in the legislature and bodies like yours, to focus on that. And by their focus, they were able to impact that ranking and make a change. So good. So hopefully that is encouraging that there is a possibility for the action that you all have to impact these rankings. And then dentist, so dentist 25th. So going on to immunizations, we ranked 21st for the percent of children aged 19 to 35 months who are fully immunized. And then the percent of adults aged 65 years and older who received flu shots, we ranked 35th. According to the National Immunization Survey, 2018-2019 information that DHHS provided, our numbers are slightly higher, but the national average is higher. So from the National Immunization Survey in Nevada, we have a 65.3% rate in that area, and then a 68.1 is the national average. And that, again, is for adults age 65 or older who received the flu shot in 2018-2019. Under physical fitness, the percent of adults who do not exercise, we ranked 18th at 28%, and 25.6 was the national average. The percent of adults who smoke, 17.6%, 17.1 is the national average, and ranking us at 19th. For the percent of adults who are overweight, we are first in the nation at 39% with 35.3. DHHS provided me with some information about 2018 information on overweight or obese. And in that area, Nevada, the percent is 67.6% of adults who are overweight or obese. And the national average is 66%. For the percent of adults with high cholesterol, 36.7% here in Nevada, ranking us at 21st. Percent of adults who do not drink alcohol, 47.1% in Nevada, ranking us at 20th. And I'll jump down to the percent of adults rating their health as fair or poor, and we rank 12th in the nation at 20.3% compared to the national average of 17.6. And so finishing out, just looking at some certain causes of death, we'll start with the death rate of cardiovascular disease. And in that area, this is the death rate of cardiovascular disease per 100,000 population, and this is based on 2019 information. We rank 9th in the nation with 302.6 deaths, and the national average is 260.4. Under estimated death rate by cancer per 100,000 population, we rank 28th with 189.7 deaths versus 189.3. Looking at the age-adjusted death rate by chronic lower respiratory disease, we rank 14th. The age-adjusted death rate by Alzheimer's disease, we rank 35th. The age-adjusted death rate by suicide, 10th. And flu and pneumonia, also 10th. The age-adjusted death rate by firearm injury, 14th. In accidents, 35th. And then age-adjusted death rate for diabetes mellitus is 44th. And so those are just some of the highlights of the statistics that are included in this document for you all to consider as you look at how you want to approach meeting the needs of patients here in Nevada, recognizing that we have some challenges, but also seeing them as opportunities, and knowing that this system, as I talked to Chair Packham, that these things all work together. And so sometimes you have to address one problem before you're able to address another.
Thank you, Marshila. Does any of the commissioners have any questions, comments? Howard. Yep.
Thank you for the presentation. Question for you: does the LCB Research Division have access to other states that are ranking well in some of these categories, and similarly, what capital expenditures they have at a local and state level for their health care? It seems to me that in looking at chronic disease management, for example, we often look at the 5 best performing centers in the country, and we try and emulate what they're doing. And it seems like we have lots of opportunities, as you said, here in Nevada. And I was just wondering whether, if we asked you, whether you would be able to produce some of that information for the commission and see whether we can take it from there.
Thank you for the question. We certainly would be happy to look into that, and we do have access to that sort of information, and would be happy to prepare that information to present or to provide to your staff.
I'd like to comment on that. The answer is yes, we actually do. And some of the sources that Marshila was drawing upon is data collected by the United Health Foundation in their annual state rankings. They now do one for seniors as well as maternal and child health. And the beauty of that document is it has a lot of state-specific information and rankings for each state, but it's also loaded with some of the best practices that I think we'll be looking for. Dr. Khan.
For the record, this is Dr. Khan. So a comment and a question on the providers' availability side. In the primary care physicians, we are 49th. I remember maybe 15 years ago, we were 49th. Granted, this data is from 2013. In the recent discussions at the new UNLV School of Medicine discussions, we were still the 49th. So that is something of concern in the sense that do we have access, or will we have access to more recent data officially since 2013?
Thank you. Dr. Packham may have even a better answer, but I believe there is more recent data. It just is not available in the format that we have this particular statistics and rankings table laid out. So there is some more recent information showing Nevada and our percentage, but it does not compare to the other states, is what we have not been able to find. But again, Dr. Packham may have more information on that.
A follow-up for clarification, when we are looking at additional data, would you be looking at the nurse practitioners as primary care providers, or primary care providers means physician providers?
So, thank you for the question. In this document, it's just primary care physicians. It does not include nurse practitioners, but certainly that information could be gathered.
Thank you, Ms. Lyons. For the record, this is Bobette Bond. I had a couple of comments. It does seem on the providers, like even though the data is older than I'm sure data that you have, Dr. Packham, that we're doing well on specialists. So we're having trouble with primary care, but we seem to be in good shape with specialists. It'd be good to drill down on that, I think. I also think there's no data here really from CHIA, the Center for Health Information Analytics, that is all state data. And I think it would be helpful to see what they can provide that's state-specific, because they are able to see data about prices that are coming in, and they're able to see data about quality. There's several quality measures that they have been able to track in the past, and I don't know if there's other data in addition to that we could add. but I do think price and quality are things that could be really fleshed out in the database that we're talking about today for future meetings, and I appreciate it.
Any other questions? Questions from Carson City?
Yeah, this is Jessica Flood. I just had, Marshila mentioned that you made progress with the dental care providers a while back, and I'd be interested in getting some information on what the initiatives or interventions were that helped move the needle on that.
And Chairman Packham, I'm nodding my head, but I know you're not capturing that. So both to Ms. Bond's comment and Ms. Flood's comment and the others, we're jotting this all down so that we can follow up with you.
Thank you.
Hi, this is Teresa.
Yeah, if I had to hesitate.
Oh, sorry, I had one question, John. On the topic of dentists, I'd be also curious how many actually take Medicaid. And I see that access to prenatal care is missing from this. This would be nice to see. And I also be interested, if possible, I know this would be very challenging, but if you pulled out Reno and Las Vegas out of your rate of physicians per 100,000, how would those numbers look? And then in terms of Medicaid and Medicare enrollees, it would be interested to see that in terms of a proportion. So how many are actually qualified versus how many are enrolled? Thank you.
Any other questions? We are taking notes.
Just following
and at the risk
up,
of sounding
oh, sorry, Jessica Flood here. Just following up on that last comment, if we could get the providers accepting Medicaid in general, not just in dentists, but primary care physicians, that would be great.
All right. Thank you, Marshila. Our next agenda item, item 7, is a discussion of commission priorities and work plan. And what I'd like to initiate this morning is a conversation where we begin to prioritize what we will be focusing on in the next couple of months. That is to say, what topics, what emphasis that we want to bring to those issues that are actually very nicely spelled out in the language of the legislation. Wanted to maybe kick that discussion off with a few comments and thoughts that I had as I've now looked at this bill a number of times. And my takeaway, my initial impressions are that at the end of the day, this bill is about improving access, addressing affordability, and at the same time making sure that we are ensuring access and affordable quality care. The perspective that I like to bring to those issues is to always be mindful of workforce. We got a little bit of a flavor of that with the presentation from LCB, but my view is that if we were to magically put an insurance card with low copays and deductible in everybody's back pocket, we might have still enormous access issues facing us given provider shortages across the gamut in this state and that were alluded to. I'm hoping that we will also be mindful of the role of prevention. I think in my career I've seen kind of the greater and greater integration of clinical and population health approaches to addressing what ails us as a state and as a nation. The Surgeon General recently released a report in which he was actually scolding physicians for still failing, in his view, to make tobacco cessation a priority in physicians' conversations with patients. And while we've made progress, it's still the case that in a state like Nevada, 1 in 5 adults smoke, so there's plenty of work that remains there. At the end of the day, and again, one reason why I was very glad to be selected to be on this commission, I hope we bring it back in every conversation, particularly if those conversations get difficult, to the first word in the commission, and that is patient, and prioritizing patients. In speaking with the majority of commissioners, I heard some pretty compelling stories that remind me of why this commission is so important, and that is folks among us who have decent incomes, decent health insurance coverage, are largely healthy. But a lot of the commissioners told me some pretty poignant stories about difficulties that they or family members had in accessing high-quality care in this state. So with that, I would like to open the conversation up to my fellow commissioners, and let's take this opportunity, in compliance with open meeting law, to just share some general impressions about the direction you'd like to see our group go. Dr. Khan.
This is Dr. Khan for the record. Some general observations to begin with. First and foremost, the staff can probably look into it. Governor Gwynn had created a patient access task force, so obviously many years ago, and it submitted its report. So it may be worth taking that out. I don't think a whole lot has changed since then based on their report, which I had looked at that time. The chairman was Dr. Anwar, so I remember the specifics of those reports. So that's number one. Number two, the charter for this commission about quality of care, delivery of quality of care, perhaps we need to narrow this down if we can. Quality of care where? Quality of care in the hospital setting. In the hospital settings, you have quality of care delivered by quality or lack of quality of care by physicians and nurses. Extended care facilities, quality of care in the extended care facilities. Are we going to look at that? Quality of care in an outpatient setting by the provider, physicians, nurse practitioners, etc. Quality of care in the diagnostic services centers. It's a pretty wide charter. One needs to somehow narrow things down where we can really make a difference and address these various aspects of delivery of service in various environments.
Tony Sloan for the record. A couple of thoughts, and thank you for sharing so much important data about our current performance. The data certainly are compelling, and I'm hopeful that we can use data as a part of our work as a commission to help advance where it is. Not only will it help us with a baseline, but it'll help us to monitor improvement efforts as we move forward with specific recommendations. The second comment has to do with, similar to Dr. Khan, areas of focus. And spending some time not only on the health care aspects of what we do, providing, making sure that when we deliver care to those people that are sick or injured, it is of the best quality, but also making sure that we have a broader umbrella that addresses health. Living well, mind, body, and spirit. And when I take on that mindset, I'm often reminded of specific populations where we've just reviewed a series of data that are not actually demonstrating our best efforts. Children who are at risk in particular, or seniors, or those most vulnerable people in our community with mental illness. And maybe there's a way for us to focus our efforts there. I'm also reminded that you can't care for people if you don't have the infrastructure issues addressed. So the workforce issues for me fall under that infrastructure, and there are other examples, I'm sure, where our infrastructure needs to be built up. But just a couple of thoughts. Data first and foremost as a public health person. So I appreciate all of the work that went into getting this report. It doesn't have to be perfect, but has to directionally move us forward. Thank you.
Mason Van Howling for the record. Just some of my thoughts, Mr. Chair, is obviously our state took a bold move with under Governor Sandoval to expand our state, but we continue to remain one of the highest, largest uninsured states in the country. So I think we just need to continue to focus on how we bring that number down and all about access. But we've got a great exchange here in our state, and how do we get patients either on public insurance or private? I still think we need to drive that. But I like the line of questioning that was coming from Carson on finding out the number of providers that are not impaneled or accepting Medicare or Medicaid. And then also, just lastly, as we continue to try to improve access, improve providers, just ensuring that we have network adequacy to take care of all these patients, that we are not creating barriers for the continuity of care. Just some thoughts.
Thank you, Mr. Chair. Babette Bond for the record. I want to go back to the way the governor opened today, and his first comments were about access and quality don't matter quality doesn't matter if there's not access, and access has to be affordable. And he did talk a lot about costs in his opening comments. And while I know this is going to be one of our difficult areas, I think it's really important for us to figure out what are the price drivers of healthcare that are hitting consumers and that are hitting plans, and what do we not know? Because I think when we get this database together, we're going to find that there's some transparency areas where we can see trends, and then there's some holes where we can't. And so maybe that's going to be big enough to be its own subcommittee, but I think that we do need to talk about the costs, which we translate into the price of healthcare, and I'd like to add that to the agenda. Thank you.
So, Flo Khan for the record. I fully agree with that, because I think the data, and Chairman, we talked a little bit about this data becomes really important to get a level set on what we know and what we don't know. And we've talked about it, from our perspective, one of the things that we've talked a lot with the governor is there's a lot of data out there, but if we need to kind of come to an agreement on what we're looking at, right, and based on different population sets. And so that would be one of the really important things that if we could get that ahead of time, that would be great. The other thing is, based on what we've already seen, agree with the other speakers as well, that network adequacy becomes incredibly important, as well as appropriateness of adherence. We're seeing some high numbers in some of the key disease states, and understanding why we're continuing to see those numbers despite many of the things that we've already done within the state, I think would be important. So those are some of the focus areas that we would like to look at.
Thank you, Mr. Chair. Sean Shaner for the record. As we take into account what Ms. Lyons shared with us earlier, particularly on providers and us being at the top of every bad list and the bottom of every good list, one thing that comes to mind for me is the licensing, credentialing process that providers must go through in this state, the duplicity that exists amongst the various systems, hospitals, health plans, et cetera, and if there's a way to possibly streamline that process. As we talk about patients, I don't want us to forget about the uninsured population. Again, as we stare back at Mrs. Lyons' presentation, 11.2% of the population not covered by health care, and then 8% of the children not covered by insurance. How those individuals are accessing care, the services afforded to them, the social determinants of health, particularly housing amongst that population. And then as we think about the interoperability amongst the systems, or perhaps the lack thereof that exists today, I know the Nevada Health Insurance Exchange, the HIE exists. However, the data sharing amongst medical record systems between physician groups, hospitals, health plans, et cetera, I'd like to get some more information about that, and perhaps some things that can be improved there. I would echo the price conversation as well, better understanding what drives that as to the various components, as well as a focus on some of the maternal child services that are available within the community and how those can further be expanded.
Howard Barron for the record. I want to expand on what Sean just mentioned. One of my pet peeves and things that drives me absolutely insane as a practicing physician is inability to easily get records and lack of interoperability between healthcare systems. It would be wonderful if everybody was assigned to the same EHR system, but that's not reality. And because we can't all afford Epic or Cerner or some of the bigger hospital-based ones. But if you work in a system in which you have to get records and we're a referral-based practice, it's virtually impossible, and it's amazing the number of person hours it takes to collect information and not duplicate things. I'm a firm believer that there's a finite amount of money in healthcare and that we don't do a very good job of stewarding that money. And I think that in the state of Nevada, if we improve communication between practices and referrals, that we would save countless dollars in doing so. So I would certainly love to see some work from this commission on that.
Darlene Roa here for the record. I would like to comment on Mr. Chairman about how just giving everybody a health insurance card is not going to be the solution, since we see a lack of providers. Is there any way we can find information on what's keeping the providers in the state? How come they are not staying and working here for us? Also, that would affect prevention, which I think it should be a focus. If we can prevent all these chronic illnesses from happening by having enough access for the patients, that would be great.
Dr. Khan, for the record, just following up on what Sean Shaner and Dr. Barron have mentioned regarding the exchange of data or data sharing between facilities, providers, I think that's one of the crux that will significantly improve the delivery of quality of care across the state. And having said that, I've studied this aspect of it quite a bit. There are some concerns or anxieties about HIPAA. My view is that those anxieties can be resolved. The technical aspect of sharing data, whether it's Epic or Cerner, can be addressed in this day and age if there is a will to do that. There is concern about HIPAA between a diagnostic facility in the town having done some scans, etc., and not available to a hospital when that patient shows up in the hospital, and vice versa. So I think if the technology people can be brought on board to figure that out, the technical aspect, the HIPAA consideration under the legal aspect can also be addressed. I think it's not a rocket science there. It's just a matter of a will and a desire to address that. That's number one. Number two, also Sean Schuner mentioned about licensing procedures. Having served on the medical board for 8 years, yes, there needs to be some tweaking of the licensing requirements of the state. We were one of the loosest ones at one time a few decades ago, and then we went to the other extreme in licensing restrictions. There's got to be a happy medium in between, where the availability of providers being so restricted in this town, especially in this state, especially in primary care. We need to get the medical licensing boards, whether it's osteopathic and or MD boards, to come on board and present some aspects of their thoughts and then come to some happy medium.
Jessica Flood for the record, up north. So I just wanted to echo Dr. Sloanum's comments about having a holistic perspective of health and spirituality. Coming from a mental health background, I feel a responsibility to advocate for mental health on this. Behavioral health comes up as one of the top priorities in most community health needs assessments. We're 51st in the nation for rankings, state rankings in the mental health rankings report. As the data shows, we're 10th in the nation for suicide, and I believe Washoe County is still first in the nation for senior suicide. So I do understand that mental health can be addressed by a lot of the interventions that we could talk about in a more umbrella perspective regarding improving workforce and reducing barriers of access to care. But I also think that there are some opportunities to examine mental health parity within healthcare as well. And finally, I just want to say, in speaking with Dr. Packham and Sarah, I was really happy to hear that they were interested in coordinating with all of these other policy committees. I think so often we have our own silos in these committees and duplicate a lot of work, and so it would be great to see us all being able to identify areas of alignment and really be able to leverage on each other's work.
was just going to comment on the licensing issue, and that is that having recently gone through licensure and credentialing for a new doctor in our practice, I can tell you that the licensing was not the holdup. It was the credentialing through hospitals and insurance agents, and we're still going through that 9 months after she has started, with still some of the payers not having completely credentialed, including one Medicaid managed care organization. And so I think that's a very, very important and something that could help expedite bringing practitioners into our state and getting them up and running.
Any other comments or thoughts? One of the things that I wanted to remind those of you on the commission, in addition to some of the assistance that we're going to get from the Legislative Counsel Bureau, as well as the agencies represented by our ex officio commission members, we do have staff, and Sarah is a staff of one right now. We hope to remedy that in the near future, but we hope to we will have the capacity to do some of that research data collection and make sure that we're getting out that information out to you and the public in a timely fashion. I'm hesitant to say that we have a website up and running, because every time we say that, it's not running, but soon, if not today, that type of information that we are discussing, any research or data collection that we will be pulling together as a commission will be publicly available on our website. Dr. Slonim.
Tony Slonim again. One more comment. Again, Patient Protection Commission, the people who are the focal point of our work and energy have to be patients. And so one thing that doesn't seem to me that we've kind of hit yet is, how do we avoid doing things to people and instead do things with them? So when you look at the physical fitness measures, we have to figure out a way to engage people in modifying their own behaviors if we're going to be successful in addressing the issues of health and healthcare more broadly. How do we engage people to take responsibility and become compliant with regimens and do the things that are preventive in nature, like reduce their weight or get immunizations, et cetera? So I don't yet know, and certainly beyond my expertise, to know the best ways to engage with participants in their health and their health care, but certainly an important focal point for us as we move forward.
Teresa Bohannon for the record. I just want to say, I want to talk a little personally, because I do have that patient perspective, and I have employer-based healthcare, and every year I go through to select my plan, and the thing I look at is, what is my maximum out of pocket? Because I know every year I'm going to hit that because of my son's condition. And for myself and my family, that's something that we can afford, but I know for a lot of families that's not the case. And each year it becomes increasingly, the max out of pocket increases every year, along with your copays and deductibles and all those things. And back to the previous comment about the system, the system truly works for the system and not always for patients. And I think that there needs to be a focus from this commission to really define what is patient-centered care, and how do we really think about the people who come into contact with hospitals, doctors, social workers. It's a complicated system, and as somebody who has a MPH, I don't think that you should have to have that level of education to be able to navigate the system. And the conversation with licensing and streamlining, I think those are very important things, but we also have to think about how do we streamline the process for patients. I've filed appeals, I've fought with hospitals, and I think that the average person shouldn't really have to do that, and I don't think the average person does do it. I think they get steamrolled by the system, and so I'd really like us to think about, how do we take a public health approach to patients and how they access care and prevent chronic conditions. And Another thing I'd really like us to think about is outside of the healthcare system. Somebody mentioned the social determinants of health. I would love to see every child in Nevada be screened for trauma, because trauma, if you're familiar with the ACEs study, those adverse childhood experiences translate later in life to chronic conditions. And if we are serious about really considering patients and their experiences later in life, if we can go upstream in any way and intervene in ways where we're helping them possibly avoid the system, I think we would be doing a good service for the children and families of the state.
Jessica Flood, for the record, I just wanted to echo those comments on the trauma screens, and also not just look at children for trauma screening, but also incorporating trauma screens for adults and using that information to develop treatment plans and discharge plans so that hopefully those people can be more successful moving forward.
Chairman, I just wanted to remind everybody, I know I said in my opening remarks that I encourage all of you to reach out to me at any time. I'm here to assist all of you, provide the support, and guide you through our path forward. So I hear you. I appreciate this discussion. I will be following up with each one of you on some of your priorities, and then for us to discuss having them a part of our work plan as we move forward and putting them on a formal presentation for meetings to follow. So you will be hearing from me, but don't hesitate to reach out to me as well, and we'll continue our conversations and try to start bringing the data forward in front of this commission and deliberating on some of the topics in more detail that we mentioned today.
Jessica Flood, for the record, I just would be remiss not to point out there's a lot of people from urban counties on this board, and I think it's important to just really acknowledge the rural struggles that are out there and really try to keep that in mind as we move forward.
So Dr. Khan, for the record, comment I need to make is about, it was mentioned earlier about patient-centered care. I think that's the crux of this whole discussion that we are having. It's about the patient. Everybody tries to do patient-centered care, but it's broken in the sense there's no coordination of care within the various provider network and systems, etc. And the quality of care that we have been talking about earlier is, for example, if you take the hospitals nationally, every hospital, I believe, tries their best to provide quality of care, but there are many parts to that delivery of service, and one needs to break that down and see where it can be improved. Having said that, you have national organizations that apparently come and give a stamp of approval of quality, whether it's JACO or other organized state and federal CMS, etc. If you look at it carefully, they're not necessarily the best in so-called declaring a facility best of quality, etc. They have some parameters. You meet those parameters, you are great. If you don't meet the parameters, you are bad. And when you declare somebody not as good or lacking in A, B, C, and D, that does not necessarily make that facility a bad facility. And that's a challenge everybody faces. The facility is declared as not good in one area or two areas, and suddenly it's public record. And I have a serious problem with that, because a facility, whether it's a hospital or extended care facility, may be providing excellent care, which is really not addressed, and we are focusing on one minor episodes here and there and just declaring. So that is a concern, and I think it's easier said than done. CMS does what it does. JACO is a private organization. My personal view over the, again, years, having dealt with hospital systems, is there. It's a financially driven organization, in my humble opinion. You have to pay an arm and a leg to get them in and get them review the process, and then they go and they see you're good or bad. So I think one has to, perhaps the state needs to look into it, whether JACO should really be a requirement of all the hospitals, not CMS. I get it, it's a whole different challenge. But the state has some leverage to get into the system and do something more objectively and not subjectively.
Any other comments from commission members on this item? Good.
Teresa
All right.
Bohannon for the record. Sorry, John.
Yes.
Just
Go
one
ahead, Teresa.
couple other things. One thing, I don't know if it's going to be in our purview, but I would love to see us at least examine public health funding in the state. We are just so far behind, especially somebody who worked on a block grant. We don't match those state dollars, and so it'd be something that would be interested to look at, and also access to prenatal care.
Thank you. I think it's within our purview to discuss all types of health spending, and if it's the nature of the way we spend dollars in the state of Nevada that public health comes up short, I think that's the data will tell us that. So any other comments on this agenda item?
Yeah, just one more comment. Jessica Flood.
Okay.
I'm just following.
I don't want to stop it. It's generated good discussion, so
Okay.
continue.
Just following Dr. Khan's comments, I thought that piece about quality of care, looking at maybe ways that we can support evidence-based practice and integrating that into care. I know other states have looked at reimbursing evidence-based practices versus, just really, looking at the quality of treatment and interventions that we have and the evidence that supports it.
Yarleni Roadugan here for the record. I want to follow Jessica on her comment on evidence-based practice. Being at the bedside, I witness this happen all the time, where my care is basically rated on, is the patient happy because I brought a pitcher of water, or I brought her crackers, instead of was she really taken care of medically. And I think that the hospital and management pushes the RNs to take care of the patients like a hotel would, instead of taking care of their medical needs. Because the patient goes out, then they get this questionnaire where the hospital is going to get rated. And based on this rating, they're going to get either good scoring or bad scoring on the box stops, or different type of ratings for the hospitals that are out there. That affects the hospital and ultimately the RN and the patient, because then we're pushed to do things that are not medically necessary, just to please the patient, not really what they need. So I think that evidence-based practice would be a great thing instead of just quality care. What is really quality care?
And on that point, I just wanted to kind of synthesize my comments a little bit more on that. So it's my understanding, I've heard this, that when we had the ACA came in, that we really spread services out to the population kind of like wide and shallow, and that's why we have low reimbursement for a lot of Medicaid providers. I understand perhaps like some of what I'm saying could be controversial, I don't know. But in terms of increasing reimbursement for specific providers such as like psychiatrists and primary care physicians, it just seems like that's where we could look at the evidence and see if there's any interventions that we're providing reimbursement for that aren't evidence-based, et cetera.
Howard Barron for the record. I would encourage, I like the discussion, and I would encourage us to look at reimbursement rates, especially for public funded patients and things like that. But I think it's important when we do that to compare to states that have a similar patient to physician or provider ratio that we do, as opposed to just our neighboring states or people or states across the board, because there's a big difference between comparing Nevada to California or Utah and comparing Nevada to Wyoming or South Dakota or Alaska, where the provider to patient ratios are much similar, and yet the rates of Medicaid reimbursement, for example, are substantially different in those places. I would just encourage that when we collect that information, that we look at those types of issues.
I think this is one of the crux of the issues in the state. At least we can address it, hopefully, at the state level. The reimbursement level and I deal with this every day in my current work situation, is the state reimbursement Medicaid products across the board, managed and fee-for-service Medicaid products, are such that nobody wants to see those patients. We just talked about earlier how many private primary care physicians want to see Medicaid patients, and the issue is whether they're compensated enough. The bigger challenge at the hospital level that I see every day literally is the patient in the hospital needs to go to an extended care facility. Hospitals don't have a choice. You walk into the emergency room, you have to take care of them, insurance, no insurance, etc. But once they are there, they need to transition in the continuum of care to the next level of care, whether it's a skilled facility, rehab facility, or long-term acute care facility. None of them want a Medicaid patient. This patient then sits in the hospital using an acute care bed, has no acute care needs, subject to nosocomial infections, et cetera, within the hospital for days, and I'm saying literally days, because no facility wants this patient and they'll tell you, we don't get paid enough by Medicaid. I have talked about this to the previous governor and to some extent our current governor. I think that needs to be addressed. This is bad medicine in terms of patient. It's bad for the system. And I know there's only so much money, but we have spent a ton of money on education, rightly so. Healthcare is essential for the people of Nevada, and if we can spend some extra money, whatever it takes, that will make a huge difference.
Teresa Bohannon for the record. Another topic I would like us to explore is the racism that exists in healthcare. I do think that having somebody who's looked at the numbers and how hospitals look at different people, I think we wouldn't be doing our due diligence if we didn't look at the racism that exists in the healthcare system.
And expand that to all minority populations such as LGBTQ, et cetera.
Chair, we've got the honor of having Mr. Whitley on our commission. Maybe for future agendas, and sorry, Richard, to ask for a report, but I'd like to kind of understand the state's budget and how healthcare fits in with education and others on, and I think that's going to be the test of our results. Are we driving that now, but also kind of widen the net on access? So it would be good to see some of the limitations on why we still have, 11% uninsured, or and then also some of the conversations coming out of D.C. in the recent Supreme Court ruling on public charge. How's our state going to view that as well? So it'd be great, and we've got Richard, he has a wealth of knowledge for future meetings, maybe talk about how we can support the division on some of our efforts, because we've got a lot of influence here on the commission, so, but also the exchanges as well. I think they've got great information and can kind of point us in the right direction on prioritizing some of our initiatives.
This is Richard Whitley. I know that Heather and I both would be happy to identify, what our priorities are, what some of the challenges are with our systems. Certainly being for coverage of people's lives, certainly at-risk people, and then on that uninsured piece, there's a nice study from the Gwynn Center that I think helps us further identify who are those folks that aren't covered. And for our part with Medicaid, it's targeted outreach. Again, back to the beginning discussion about data. It's looking to see who's not covered and why they're not covered and where are they, and requiring us to do business differently. Related to the healthcare system, we'd be happy to provide an update on really just the expansion of Medicaid, and then almost as soon as we expanded it, the federal government started tinkering with it, and so we're trying to mature our state system at the same time, predict and also respond to federal changes. And it's specific and it's impacting, and I wouldn't do it justice just to do an overview here, but I think it would be good in a future meeting to just check the status of where we're at. I think along the lines of the data and where we need to go, just a baseline of where we're at, and just some of the vulnerabilities that in real time as they get rolled out by the federal government.
I'm Bobette Bond for the record. Expanding on that a little bit, in the document provided by Ms. Lyons, the first per capita item is state and local government. Is there a way to look, this might turn us into a Ways and Means Committee, which is not my goal, but is there a way to look at what's coming in federally, what's coming in statewide, and what's coming in local, and where it's going? Because I think often in the legislature you'll see the state funding, but you don't see the federal or the local. It seems like everything's a bit fragmented. I don't know if there's an easy way to put that together so that we can kind of see what we're talking about. And I don't know if we'd still be 41st, but we do need to understand the money to understand resources and access and priorities. I think that was to you, Mr. Whitley.
Oh, well, I was waiting for the question, I guess. Nothing comes to mind that's ready-made, but I do think that it gets at, the infrastructure piece, that we have to understand that it isn't just state, it isn't just federal, it isn't just local. So how do those all intersect? And putting that together, people experience their health care locally for the most part, and so I think putting that together as an infrastructure, and then as much of the discussion has occurred, there are populations that then have to navigate that bring their own experience. So I think having a foundation of like that system of healthcare, how it's paid for, describing it federal, state, and local, and then looking at the populations that access it or have challenges with it, might be a nice way to consider framing it.
Talking about access again, the fact that more people are insured thanks to the Affordable Care Act is one aspect of it. The question comes up is they have access, at least getting to see somebody, whether they can continue to have access in their continuum of care for themselves holistically. Having access to a primary care physician or having access to an emergency room. For an emergency room, you get access irrespective. For a private provider, the access is based on cost, so because they have a choice to choose one or the other. The access gets challenged, again, if you have insurance, that's one thing, state insurance I'm talking about, Medicaid products. The access gets more and more restricted in the hospital, and I'm not belaboring the point, but I think it's crucial, is when that access, you get into the hospital, you're stuck in the hospital. You don't move forward from there because of that inadequate access beyond the hospital. And that's a challenge. You take away 10 beds from a hospital. This should probably be coming from Mason, but I see it as a provider, is that when you get into a hospital and your 10 beds or 12 or whatever number of beds are taken up by these patients who cannot move on beyond, you're taking away those 10 beds from patients who are denied access because there is no beds. And you see in southern Nevada, and Mason, you can talk to it, is that the hospitals are often on divert. They cannot, their capacity is full in the emergency room because there are X number of beds who are not moving out of the system because of the problem of access beyond the hospital. So one can control the hospitals with access through emergency room by law, et cetera, et cetera. But beyond that, there's a huge restriction in moving and opening up those beds, talking about access for new patients to come in.
I think in addition to that, another important piece for consideration is the social justice perspective and the patient flow and where patients end up and where they connect with different providers. And Richard brought up, these special populations and how they access care in our population. I think criminal justice reform is actually part of this purview. This is very healthcare focused and heavy here, but a lot of our patients do end up in the criminal justice system. A large percentage of people who are incarcerated have chronic health needs and mental illness. So just to keep that on the table for consideration as well.
Just to kind of follow up with that point, just thinking about the auxiliary points of entry into the system and thinking about some other opportunities like school-based health clinics. I don't know where we're at with those in the state. I know there was a push at one point, but thinking about other opportunities to seek healthcare outside of the tertiary that we're talking about, hospitals, and learning from patients too about how they're accessing care, what their barriers are to accessing care. Because what I'm hearing, there's a lot of, once people are in that tertiary system, but honestly, a lot of times, and I'm sure the people that are in the hospitals can speak to this, there's probably so many steps that could have prevented them from being in that tertiary care. So where are we missing those folks? And what are our opportunities to speak to them and to learn what those barriers are, and what can we do in our capacity to reduce those barriers?
Bobette Bond for the record. I think to that point, I appreciate the perspective that the patient's going through this terrible navigation process. I'm really glad you raised that, and I'm really glad that's going to be on the agenda for how the patient navigates the system. And I appreciate your comments, the comments about barriers too, but I think we also have to consider the flip side of this, which is the way incentives are created. I think the barriers are the flip side of incentives, and I think that we need to take a really clear look at what is and is not incentivized in the current system and how that is paid for. And we're talking a lot about the public funding. I think that's very important charge of what's going to end up being this group's work. But I think the private sector has a lot to do with what does and does not get paid for as well. So I just don't want that to get lost. I think we get what we pay for, and I think we should be looking at it, clearly.
Darlene here for the record. Talking about the barriers for healthcare, I believe that the biggest one for most patients, at least for the people that I get in, that I talk to, my patients and friends, it's basically the cost of healthcare. Most of them have insurance, but there is a high copay, or depending on what the treatment is, even if it's preventive, the cost is just inflated. People that need to basic medications for diabetes or hypertension, chronic illnesses, they have to choose between their medication or preventing maybe a worsening of the illness for either rent, food, or other living necessities. So I would like us to explore the option of any way that we could control the cost of healthcare. Like, is there anybody that can oversee how much medications cost, how much a treatment can cost? Who says that just because you need to get, let's say, a C-section delivery at the hospital is going to cost $3,000? So who is managing that? Who is overseeing the cost? Because I believe that it's inflated. I come from a third world country, Colombia, and talking to some friends that live there, they ask me, why is the cost of healthcare so inflated in the U.S., since this is supposed to be the country where we have more access? Why is the cost so inflated for medications? I think that if we can make those costs lower and accessible for everyone, then we should be able to prevent chronic illnesses.
So FloCon for the record. I do think it's important, and it goes back to, I think, what Jessica said. It's all going to be about education, right? We have so many new lives that are coming into our healthcare system with the expansion of the ACA, and that's a really good thing. But as was noted, a lot of these people have never had access to the healthcare system before. And so they're just learning for the first time how to navigate that system. And so an education program of some kind would be really important. And that goes to coverage. What does coverage mean? What does insurance provide? And that goes to a little bit back to what you're saying as well. We need to help them understand what products are available to them, both in the public and private sector, and then explain to them how what is best for their individual needs. Because too many people, they're basing it initially off cost in the short term, but in the long term, it is costing them more because they don't have the appropriate coverage that they need to treat their particular disease state, chronic illness. So we really need to figure out, how do we educate those folks out in the community on what's best for them and their needs, so that they're making longer term decisions on their health care. And that also includes some of the other education things that we need to do, as well as prevention and, getting them healthier choices, and, vaccines and those types of things. So I think it all goes together.
Teresa Bohannon for the record, and just to follow up on that, if we're going to talk about health literacy and increasing people's health literacy, we need to incorporate cultural competence into that, because you cannot expect people to be told something if you're not speaking to them in a way that they understand, or they're going to be accepting of that information. And oftentimes, when we go about these things, we kind of operate in our world and how we speak to one another, and we need to be mindful of ensuring that we're speaking to people where they're at.
Dr. Khan, for the record, just an observation based on the data you presented about the availability of providers in the community. There is no dearth of dentists in our community, and if you look at national data, dental shortage is not very well documented. Generally, it's reasonable. One of the reasons, and one of the reviews a couple of years ago I read, I forget where it was, but that specialty is fiscally rewarding. It's all cash pay, and the specialist feels good about being there because he gets compensated well. The least rewarding specialty today is the primary care physician. And so the primary care physician's fiscal reward is not as significant as he or she expects it to be, and therefore less and less people are going into primary care to begin with, because it's not even fiscally rewarding. And that is not fiscally rewarding for both public and private sector reimbursement. Generally, it's considered not enough for them to go into primary care, and therefore, if they do primary care, they go into specialist category, and therefore our specialist numbers look much better compared to primary care.
Howard Barron for the record. So that said, our specialists are overburdened with things that really should be taken care of in a primary care situation. And I want to point that out as a subspecialist in pediatrics, that probably 30% of what I do and see on a given day really should be handled in the primary care pediatrician or family physician office. And were it not for the time that those individuals have per patient because of reimbursement rates and things like that, that some of those things would never trickle their way over to our office. And so bolstering primary care is I think could have a huge impact on our state.
Thanks, Babette Bond, for the record. I just want to respond to a couple of things. I think only because you raised dental again, Doctor, I think that bringing back the information about how dental numbers changed in Nevada is really important. We were a big part of what that push was, and it was change in the way licensing was. We were 48th in the state. Over the last 15 years, we've become 25th, and that was due to policy changes that Marshila talked about, proactive changes in the way things are licensed. So I just wanted to put that on the record as you're talking about the reason we're 25th. I also want to go back to price. I think that if we did a poll in this valley of the number one reason patients struggle with their health care, it would be price. It's nationally price. I don't know if there's a state survey like that, but I think that we shouldn't get too far away from, as we raise all these issues and barriers, it's the price of health care that's making health care a crisis in our country. And I just want to make sure that that stays in all of these threads because it's impacting every arena we're talking about. Thank you.
Any other comments? All right. Well, I don't think we've heard the last of the conversation on many of these issues, but I do want to turn to Agenda Item 8, and as I think this discussion has precipitated some potential, more than one potential agenda item and presentations for future meetings, I wanted folks to look at their calendars. We can decide at a later date, final meeting times, but wanted to try to get a sense from commission members as to meeting times. My preference, given everything we have discussed and we need to tackle in the next 5 or 6 months, would be a monthly meeting. My preference would also be to calendar that on the first Wednesday of the month, so we're not running up against the Interim Healthcare Committee, maybe putting a little space between them and their regular meeting agenda. But wanted to ask the group preferences, and Sarah and I will take your comments and work towards putting together a calendar, I think, for at least the next 6 months, if that's agreeable. Any thoughts or comments?
So once a month may be all right, but the agenda to address is pretty huge. So, but I understand the limitations on time and availability of all the members. Personally, and it's not a hard and fast thing, Mondays look good for me, just like today. If that is a possibility and if the other members feel that's reasonable, that would be my personal preference.
Other comments? Bob?
Thank you, Mr. Chair. I was just trying to clarify what kind of input would be helpful because I'm sure trying to get to all of our calendars is going to be...
We'll have it figured out in minutes, I'm sure.
One question for the chair is if there's, for example, you mentioned the first Wednesday of the month. I know, for example, the first Wednesday of April, I'm going to be out of the country, but be that as it may, what is the policy in terms of sending a representative? I understand that person may not have a vote or something like that, but can you expand on that?
I will seek the guidance of the fellow at the very end of the table there, but I believe that we have some latitude on including commission members for travel and so forth, but I'll defer.
Deputy Attorney General Greg Ott, yeah, you do have that sort of latitude. I'm happy to speak to specifics if you want, but yes, you have that latitude.
We'll talk later. Other thoughts? Well, I think I will have Sarah reach out to everyone and calendar-wise, but I'm quite keen. I know Dr. Barron has patients that are already in his calendar for the next couple of months, and among other things, we'd all like to get some clarity on that. So I will have Sarah reach out. Any other thoughts or final comments on potential agenda items and presentations? I think in addition to calendaring and scheduling, we will be following up with everyone on that. I've written down a couple of pages of notes already on potential agenda items, and I believe we're actually gaining some focus here, which is very nice to see. Other item? Sarah, did you have anything?
No, I feel like I'm going to be I'm repeating myself, but as we start developing the next agenda the agenda for our next meeting, again, I will be reaching out to each and every one of you to follow up on some of the topics that you mentioned and looking to get some of that data put together in a formal presentation to the commission. You know, this is going to be the forum for where we bring the data, have the discussions, and so I will be reaching out to each one of you. Please reach out to me. I'm here to help support each and every one of you and look forward to continuing our work.
Go ahead. Yeah.
So FloCon, in terms of like the subcommittees, obviously there was a whole breadth of issues that were presented today that ranged from, provider adequacy to insurance coverage to pricing to everything. Is there a plan to like break those up and have different individuals from the commission who are interested in different topic areas join those subcommittees or subgroups and then work on those agenda items? Or, is there any thought around that?
There's a lot of thought around that, and there's been a lot of discussion. I think almost to a person, everyone I've spoke with has had ideas on the role and purpose of subcommittees. I think it's a great thing to have in our tool chest. My only insistence was that we try to have still some initial conversations where we're all at a table, but there are a couple of dozen topics that would be ideal for a subcommittee to take a deeper dive. But so what I'd like to propose is that we almost keep that as a standing agenda item or something that we're thinking about and discussing at every one of our regular commission meetings, and just continue that. All right.
Thank you, Chairman. Bobette Bond for the record. I guess my initial reaction here is I think the subcommittees are going to be a saving grace, because I think if we're meeting once a month on this plethora of really difficult, issues that we know are going to take time and thought, and bringing in what other states are doing that are great and bringing in expertise we haven't considered, I think the sooner we can figure those out and get them rolling, and if they have to meet more frequently, the better, because I think that time goes really fast in these processes in the past. Thank you.
Time is going fast. Other items? Okay. I think at this point, I want to open it up for second public comment. See if there are any individuals in Las Vegas that would.
Hello, my name is Dan Leiden, and I am the Director of Data and Analytics at the Gwynn Center for Policy Priorities. We at the Gwynn Center, first of all, want to voice our support for this commission. Our policy research and recommendations at the Gwynn Center are grounded in carefully sourced and rigorously analyzed data. Based on the discussion over the course of today's meeting, it does appear that the commission strongly shares this commitment to evidence and data, and we're very hopeful that this will be a through line for all of the work that is done over the course of these meetings. We at the Gwynn Center hope that we can be useful to the work of this commission, and we look forward to working with the commission over the coming months and years. Thank you very much.
Thank you. Seeing no additional public comment here in Las Vegas, is there any public comment in Carson City?
Joan Hall, representing Nevada Rural Hospital Partners. Appreciate the conversation today. The issues discussed are the same for the safety net providers that I represent. But I think there's three topics I haven't heard anything about, and that's transportation for patients, especially in rural areas, whether it's just to their doctor's offices or whether it's interfacility transportation. Those really affect patient outcomes, as does our pre-hospital care. In most of the rural communities I represent, excuse me, we still have volunteer EMS services, no paramedics, so that pre-hospital care, especially for long distances, really impacts patient outcomes. These volunteers are wonderful, they're selfless, but they have other real jobs that take away from their training and education, and they have to leave their jobs to respond to a call. So I think that's something that the state should look at, or counties. It's an issue for us. The other issue is the offering for Medicare managed care insurances for rural residents where the hospitals aren't in contract and the providers can't get credentialed. So these individuals think they have a less expensive Medicare option, but their providers, for instance, for the people in Hawthorne or Tonopah, their primary care providers are listed as Las Vegas. Or the people in Ely, their primary care are listed as Reno. So that really is a disservice for these Medicare recipients. So I'd hope that the commission could consider those. Thank you.
Thank you.
Thank you, Mr. Chairman, members of the commission. Tom Clark here on behalf of the Nevada Association of Health Plans. I want to first thank the governor for his leadership on this issue. The legislature, of course, for passing the bill that brought you all together. As you can tell from the last couple of hours of testimony, you have a lot on your plate. And the association represents all of the major private insurers in the state. Whatever we can bring to bear from information, data, perspective, experts, whatever you need, we are ready, willing, and able to help. So Godspeed on your efforts, and whatever we can do with the commission and with the subcommittees, we're here. Thank you, Mr. Chairman.
Thank you. Anything additional? All right, I believe we've covered all of the items on the agenda. If you've made lunch plans, you can keep them. And we are hereby adjourned. Thank you.